Good afternoon, everyone, and welcome to today's webinar on the Prematurity Campaign Collaborative. My name is Lee Forbush, and I work at the National Institute for Children's Health Quality, also known as NICHQ. And this webinar is the fifth webinar in NICHQ's Infant Mortality Expert Webinar Series. We are delighted to be partnering with March of Dimes for this webinar today. I'd like to encourage everyone to connect to the audio through their computer. If you are just joining us by phone and are experiencing any technical difficulties, don't hesitate to contact Amal at the number on the screen. And please note that because of the size of this webinar, we will have all participants muted for the duration. And so we encourage you to ask questions through the chat box function. You see there's a chat box and there's also a Q&A box. We recommend the chat box that we'll be monitoring throughout the webinar. At the end of this webinar, we will have about 25 minutes for a question and answer session, so we encourage you to chat in your questions throughout the webinar. And as a reminder, all participants will receive a copy of the slides and recording at the conclusion of this webinar. I'd like to turn it over to Scott Burns, the President and CEO of NICHQ, to introduce today's speakers.
Thanks, Lee. Good afternoon, everybody, and good morning to those on the West Coast. It's a real pleasure for me to introduce our two speakers today. Our first speaker is Dr. Paul Jarris, who is the Chief Medical Officer and Senior Vice President of Mission Impact at the March of Dimes. His overall responsibilities include advocacy, maternal child health, consumer education and professional training, the Perinatal Data Center, and the NICU Family Support Program. Dr. Jarris is a nationally recognized expert in healthcare policy, clinical quality initiatives, public health, and disease prevention. He previously served as Executive Director of the Association of State and Territorial Health Officials, ASTO. He is board certified in family medicine with over 20 years of clinical practice and received his MD from the University of Pennsylvania School of Medicine and an MBA from the University of Washington. We're also going to hear from Dr. Lisa Waddell. Lisa is the Senior Vice President, Maternal Child Health and NICU Innovation, and Deputy Medical Director at the March of Dimes. She previously was the Chief Program Officer for Community Health and Prevention for ASTO. She has over 23 years of national, state, and local public health experience. Dr. Waddell is board certified in preventive medicine and public health. She received her medical degree from the Medical College of Virginia and her Master of Public Health from the University of North Carolina School of Public Health. She's also a graduate of the National Public Health Leadership Institute. So please join me in welcoming Dr. Jarris and Dr. Waddell to talk about Prematurity Campaign Collaborative.
With that, we'll turn it over to Dr. Jarris.
Well, thank you very much, Scott, and colleagues at NICHQ for holding the expert series, but also inviting the March of Dimes to participate with you. It's a real pleasure. Why don't we go on to the first slide, or next slide, excuse me. So I'll be talking a little bit today about the National Prematurity Collaborative that we're engaging with many partners across the country, over 180 groups, organizations, and individuals. I'll tell you a little bit what's behind it and where we're going and encourage all of you to become engaged. And I'm waiting for a slide change. Has that happened? Or do I change it?
Paul, you can change the slides.
Magic, thank you. Okay, so I just did our intro. So we think we're at a very serious point in our country and received a real wake-up call. So we're going to talk a little bit, again, about the context for the collaborative development, but the collaborative is really a tool, basically to create a movement, to engage many organizations with vast expertise, some overlapping, much of it unique, in trying to move in the same direction with each other. We all know that prematurity is such a complex issue that no organization and, frankly, no field can solve it alone. So we're really trying to engage across all of the many organizations and many fields in addressing this. As you can see from this slide, it was about in 2003 when Scott was at the March of Dimes that the March of Dimes identified really preterm birth as a major issue, but early elective deliveries is a major driver of preterm birth. And as you know, early elective deliveries are deliveries that before 39 weeks with no medical indication. The national campaign really kicked in and started to see results in 2006, and many, many organizations joined the March Dimes, from governmental organizations to other quality organizations like NICHQ, public health organizations, consumer organizations, professional organizations, and we saw between 2006 and about 2013 continued declines as a result of our work that we all did together. You'll see the green bars here. Those are the based on the last menstrual period, a woman's recollection of when her last period was, which is then used to estimate gestational age. In about 2014, the United States went to what's called OE, or obstetrical estimate. This is based on an early ultrasound and is a more accurate way of calculating gestational age. It is also how the rest of the world does it. So finally, we switched from the inches to centimeters in 2014, and now we can compare across the world. So of concern, however, though, is after years of decline, between 2013 and 2014, we saw very little change in preterm birth. 2014 to 2015, even though you don't see on this slide, I'll show on the next slide, we saw an increase, and again, 2015 to 2016, an increase. So our curve has reached an inflection point, and we now have 2 years of increasing rates of preterm birth. So you can see in a little more detail here with the 2014 to 2015 increase. It was statistically significant, although not a large amount. But unfortunately, this accelerated from 2015 to 2016. We saw a 2% increase, additional increase in preterm birth, which represents around 8,000 additional babies being born preterm than would have been born had we had the same rate as in 2015. So another 8,000 babies put at risk. And as you know, being in this field, that preterm birth and the associated conditions are the largest killers of babies and children up to age 5, and preterm birth and associated conditions are the largest cause of prematurity, which is why we focus on that. You can see on the right side how 2014 to 2015, as we mentioned, the increases were in non-Hispanic blacks and the Hispanic population. 2015 to 2016, all racial and ethnic groups saw an increase. However, if you look at it, women of color still saw a larger increase and increased the gap. So as a nation, we are both doing worse overall, and in addition, we are doing worse in terms of our goodness and equity. And as you know, and I don't believe I have the slide in here, in terms of highly developed nations, the United States is near the bottom in terms of our preterm birth rate. So the question is, what's going on? And this is something we are working on with our peristats and at the March of Dimes and our statisticians, along with the CDC and the National Center for Health Statistics, to try to dig down further into what's going on here. But there is this saying, and attributed to many, but I believe it was actually Paul Batalden in the quality improvement movement, that every system is perfectly designed to get the results it gets. So we have to ask ourselves, if we are doing so much worse than other nations, how is our system perfectly designed to get worse results, both in terms of overall preterm birth rates and these persistent and completely unacceptable inequities? An important study we look at is this Intergrowth 21st project, which was a longitudinal study. This particular paper and information took a look at women across multiple continents, all continents but Oceania and Antarctica. These were women of different races, different ethnicities, and obviously different geographical locations. The women chosen were women in optimal health for pregnancy. So they were, right age group, they didn't have any associated health risks. They were actually in the socioeconomic status where they were supported, they had resources, they lived in safe communities, and they were put into a standardized prenatal care package. Now, you might wonder why we would study women like that instead of women at risk, but there's an important reason. What the study found was that under optimal conditions, women of different races and ethnicities in different geographic locations had similar birth outcomes. In fact, the differences between the women in the different races, ethnicities, and locations were smaller than the differences within those groups in geographic locations. And so we really cannot continue to use this excuse in the country that, oh, we're a diverse nation, therefore we have inequities. Race, ethnicity, national origin are not the sole determinants of birth outcomes. And importantly also, in addition to this fatalistic narrative, oh, this is genetically predetermined, we can't do anything about it, we really have to call into question this notion of group flaws, which we have in this country. Oh, if only these women lived differently, behaved differently, did this or that differently, that we wouldn't have these differences. These are not a matter of group flaws. We know that African-American women with more high school or college education or more still have preterm birth rates greater than non-Hispanic white women with less than a high school education. So it's not just a social determinant, there's a toxicity in this country experienced by women of color based upon historical, structural, and social determinants for advantaging some and disadvantaging others. And we feel this is something we absolutely have to look at as a nation and certainly as a group of partners in this profession. So seeing early on that we were increasing from 2014 to 2015 and being concerned about that, at the March of Dimes we pulled together a group of about 30 different experts in the area, all the way from governmental agencies, which include CMS, CDC, Maternal Child Health Bureau, Office of Women's Health, Office of Minority Health. We pulled together ACOG, A1, AAP, the maternal fetal medicine specialists. We pulled together public health organizations such as APHA, ASTO, NICHQ, and then we had community-based organizations such as Healthy Start, City Match, Jack and Jill, and then parents together for 2 days to really look at this issue and develop a strategic approach to it for multiple organizations to align. So this is a lot of words, so you don't have to look at it all at once, but the central challenge, the group came back and said what we absolutely have to do in this country is work both to achieve equity and improvements in preterm birth. We can't just work on one or the other of these. We have to work on both if we're going to get where we need to be. In this country now, children under age 5 are minority majority. That means the majority of pregnant women are minority majority. So unless we close these gaps, these historic gaps that we have in this country, we will not actually ever achieve health as a nation at the level we need to. And in addition, we won't overcome the social injustice experienced by people in our nation. Underneath that, and I'll go quickly because I think Lisa will talk more about it later, we had 5 work groups that we thought were essential. One is looking at clinical and public health practice. We know there are many interventions not fully optimized, whether in public health that's smoking or pregnancy prevention programs or programs to create intentionality, improve intentionality. We also know in the clinical sector there are very important evidence-based interventions such as aspirin for preeclampsia or aspirin for prevention of preeclampsia or 17P for women with a history of preterm birth, that women simply are not receiving the services we know they should be receiving. And of course, those are complex back to the system that does not line up so that women get what they need. So that group is working on that. Lisa will talk more about that. With research, again, this is a complex issue, and there is some groundbreaking research going on. Some of it I'm really proud of at the March of Dimes is looking at epigenetics and how stress, including racial stress, may affect the regulation of genes and therefore birth outcomes. So there's some great work going on in the biological sphere, but we also know that this issue is more than just biologic or clinical. We have to start looking at social sciences, whether it's anthropology or sociology or economics and others, because there's so many factors driving our system and the health that results from it. So we have a research group we'll be pulling together to work on that. We also want to bring together, have an emphasis on translation as well as community-based research and intervention. The first group we pulled together was our health equity work group. We brought together around 30 different experts around the country, all the way from academics to practitioners to community groups. And the question is, how do we take both the science and the practice of equity and apply it to preterm birth? And that group is very active, again, as Lisa will talk with you about later. We have a group that's working with communications, a diverse number of organizations looking at communications, and how can we align across multiple organizations. For one thing, how do we create the largest killer of age, make the largest killer of children to age 5 a priority in this country, because very few people know about that, and it doesn't receive the urgency and the attention it needs. But also, how do we talk to specific groups about in a way that's culturally and linguistically appropriate so they can engage on this work with us. And our policy group met today for the first time, really looking at how do we impact policies that can lead to equity and healthier babies, all the way from policies, structural determinants, social determinants, as well as health and healthcare related areas. And then finally, resources are something we are looking at, both to support the collaborative and the work involved in this to support care for women, such as what's going on in health reform right now, but also looking at issues like prematurity and other groups that we might need to more work in the workforce out there. And that group is still being started up. So I'll go on and skip over the details. You will have the slides. So the way we're organized is we have a steering committee. It's made up typically of the CEOs or executive directors of leading organizations in the area. Scott, I believe you're on that group. And they're guiding the overall collaborative. I want to be really clear, this is not the March of Dimes going to people to say, this is what you need to do, this is what you want to do. Our staff, as you can see at the bottom of the slide, are trying to organize and provide support as we bring together these groups, and collectively they engage and decide upon priorities. And then we have the work groups that Lisa's going to go into more detail on beneath that, who are very active. These are just some of the organizations engaged. As I said earlier, we have about 180 organizations and individuals now. We would love to have you get engaged and bring your expertise to the table and throw in a hand at some of the work we're doing, which Lisa will discuss more about in a minute. Overall, in the steering committee, Dr. Wanda Barfield, Admiral Barfield from the CDC, who, as I'm sure you all know, is the Director of Division of Reproductive Health, is co-chairing, and I'm co-chairing with her, the overall steering committee and group. And Lisa will go a little bit more into the health equity work group, the clinical public health work group, and the leaders there. But we're trying to have somebody from public health and somebody from clinical, or somebody from community and somebody from academic. We want to balance the co-chairs so that there's different perspectives brought in. And with that, I think I'm going to turn it, Lisa, over to you.
Thank you, Paul. Are you all able to hear okay?
Yes.
Okay, great. So good afternoon to everyone. I want to share with you a little bit more about the exciting work that's going on currently in our collaborative work group. As you heard from Dr. Jarris, the collaborative has organized itself into 5 work groups. The 2 most active work groups to date are the Clinical and Public Health Practice Work Group and the Health Equity Work Group. And as you heard from Dr. Jarris, our Policy Work Group kicked off today as well. So the charge of the Clinical and Public Health Practice Work Group is to identify clinical practice areas in need of development. For example, what more do we need to do to increase the uptake of aspirin prophylaxis and to reduce preeclampsia? To identify what are some of the systemic approaches to achieving quality and reliability, and to really look at what are some of those best practices that we know there are known interventions, but they're not being fully utilized. This work group is being led by Vanessa Lee with the HRSA Maternal and Child Health Bureau. Many of you know Vanessa because she is the National Coring Coordinator out of HRSA, and Dr. Dorn, who is with ACOG. The work group has met 4 times and has identified 2 initial priority areas. One of the areas focuses on pre- and interconception time period, and the second area focuses on the time period during pregnancy. So as you can see from the slide, in terms of priority 1, the focus here is to expand opportunities in public health, primary care, and women's health care settings to increase intentionality, achieve healthy birth spacing, and improve pre- and interconception health. The group really wants to focus on what more do we need to do in the area around promoting healthy birth spacing and intentionality. And we'll be discussing what are some of those things as we continue our work with the next meeting. The second area is around extending the effective use of specific evidence-based practices to high-burden populations for whom the practice is unavailable and underutilized. And specifically here, the group is interested in focusing on how to increase the uptake and utilization of low-dose aspirin to prevent preeclampsia, and then also how do we increase the uptake and utilization of 17P for preterm birth reoccurrence for those women who have had a prior spontaneous preterm birth. The next meeting of this work group is going to be on October the 27th, and if you're interested, we certainly invite you to join us with that particular work group. I'm trying to advance the slide. There we go. Okay. So the next work group that's been very active is the Health Equity Work Group. This work group is being chaired. Well, actually, we have 3 co-chairs with this work group. Fleta Mass-Jackson, who is the president and CEO of Save 100 Babies. We have Dr. Art James, who many of you all know, who is with the Ohio State University, and Dr. Diana Ramos, who brings the public health perspective, working with the Los Angeles Public Health Department. So we have the sociology perspective, the clinical practice perspective, and the public health perspective all coming together as we look at the opportunities to address the health inequities to improve birth outcomes. This health equity work group is also very active. It too has met 4 times. It's charged with developing communications about health equity and prematurity, identifying and spreading best and promising practices and policies, and serving as an expert resource to the other collaborative organizations and work groups, and identifying resources to achieve improvements in preterm birth and health equity. Similar to the clinical and public health practice work group, it too has identified a couple of initial priority areas. The first is to create a consensus statement. As you heard Dr. Jarris mention earlier, that we know that we need to engage other disciplines and to better understand what is contributing to these birth inequities. And so this group is going to work on a consensus statement that brings in other disciplines to identify what are some of the challenges, try to better understand the issues, and to propose what some of those solutions might be. And then this group also is working on a glossary and a set of guiding principles. They want to make sure that there's a document there that ensures a set of common terminologies that are fundamental to the principles of health equity. And hopefully that will help groups as they are having conversations around this topic about how to advance equity and health equity. And that this set of guiding principles will be helpful as the other work groups or other organizations who may not have a set of guiding principles think about how they frame their work as they go forward. So those are the 2 initial things that these work groups, that this particular work group is focused on. When this work group meets, part of what we are beginning to do with this work group, as well as our clinical and public health practice work group, is to utilize part of the work group time to highlight best practices when we hear about things that are working, so that we can leverage all of the brain power that's on the phone to hopefully spread what's working across the country. Additionally, we have the communications and the policy work groups of the collaborative. The communications work group had an initial meeting in July of this year. That group really wants to focus on a grassroots advocacy effort that really will engage women and mothers to support and advance policy goals. So the communications and the policy work group, to some degree, will be complementary to each other. As you heard from Paul, the policy work group met today. They want to identify what are those advocacy initiatives at the federal and state levels that can help to reduce disparities in preterm birth. They plan to meet again in early October to prioritize one or more advocacy initiatives. And then the communications group can leverage that and can determine how can we best mobilize mothers and women to support and advance those policy goals. There's certainly a lot of opportunity there as both of those groups really get off the ground. And then our final two work groups are the research work group and also our funding and resources work group. The research work group is really in the planning stages. It certainly will be looking at a consensus statement that will really tap more into the biological types of sciences with that particular consensus statement and potentially a publication. So they'll likely be launching a little bit later this year. And then certainly the funding and resources work group, as you heard from Paul also, will be an important work group and likely will not launch until early 2018. So we have the structure in place to do this work across the country with all of you. So I want to move into, so what are some of the opportunities for collaboration that we see with this National Prematurity Campaign Collaborative? Well, one is around the issue around birth spacing or interpregnancy interval. As I mentioned, the Clinical and Public Health Practice Work Group has decided that one priority area is around birth spacing and intentionality. And we know that birth spacing or the interpregnancy interval is the time between a live birth and the conception of the next pregnancy, and that birth spacing of less than 18 months increases the risk of preterm birth, low birth weight, and a small baby for gestational age. And unfortunately, 33% of the U.S. births have a short interpregnancy period of less than 18 months. So if we're looking at how to impact preterm birth, this is an area where we believe is an opportunity for the collaborative to engage in some work with many others. As you can see from this slide, this shows the results of birth spacing, a meta-analysis around birth spacing and risk of adverse perinatal outcomes. This was an analysis of 67 studies that found that interpregnancy intervals shorter than 18 months are significantly associated with increased risk of adverse perinatal outcomes, including preterm birth, again, with the interpregnancy intervals of less than 6 months having the highest risk. And the next slide will reinforce this, that this is a study that came out of the Stanford Prematurity Research Center that affirmed that the risk of preterm birth increases with interpregnancy intervals less than 18 months. And you can clearly see this on the slide with this odds ratio of 1.71 for a preterm birth with an interpregnancy interval less than 6 months. So this is an important area and a real opportunity for more work to be done. And so when we talk about the issue of intentionality and planning pregnancies, again, it's an important intervention, and we know that there are all types of choices around contraception, but some are highly effective, and the long-acting reversible contraceptives are highly effective, and they can have a significant impact on reducing unintended pregnancy, allowing families to sort of plan and space those pregnancies. And we have this information from the Colorado Initiative to Reduce Unintended Pregnancy that was aimed at reducing unplanned pregnancies by providing these intrauterine devices and implants at no cost to young, low-income women. The results show that the birth rate decreased 48% in women ages 15 to 19 and 19.4% in women ages 20 to 24. Repeat teen births dropped by 58%. And also importantly, there was a 12% decreased risk of preterm birth. And of course, there were cost savings to the Medicaid program. So there were economic benefits and benefits from a birth outcomes perspective. And so, but we also know that to increase the availability of these devices in communities and across states require important systems work. There are lots of potential barriers, and many states have taken on initiatives to make improvements in increasing access to contraceptives and choices for women, but there's certainly more to do in this area. Another intervention that's important in terms of thinking about that interconception period is the implicit model. And implicit stands for interventions to minimize preterm and low birth weight infants. It's a continuous improvement process, and it's something that has come out of Pennsylvania and a family medicine education consortium who had a goal of reducing preterm birth and low birth weight through patient care and working with residents in education and continuous improvement. And what they're really interested in doing is that we know that mothers are bringing their babies in for their visits from the time of birth, that 2-week visit up to 2 years. And so is there an opportunity there to also provide some interconception type care and education for the mothers? And so it's an opportunity through this model where they are focusing on behaviors such as smoking, depression, sharing information about contraceptive use, reminding mothers about the importance of multivitamins with folic acid. So again, trying to optimize education and interventions during this interconception period. And so it's another tool that's out there that through a collaborative process, it's a way of spreading knowledge about it and how to potentially increase the uptake and utilization of this intervention. And so now we'll turn it back over to Dr. Jarris to talk about opportunities around low-dose aspirin.
Thanks, Lisa. So this is a very interesting area to me because here we have a drug, a baby aspirin, which costs maybe 20 cents a pill, and yet it's not being provided to women. The research is pretty good on this, and I encourage you all both look at the ACOG guidance, but also the U.S. Preventive Services Task Force, which did a meta-analysis of all literature out there and made this recommendation. So basically, you know, preeclampsia we know is not common, but it is almost 4% of U.S. deliveries, and it can range in certain populations up to 8%. There are risk factors, both hard risk factors like a history of preeclampsia in the past, and then softer ones. But unfortunately, it's high in women who have never been pregnant before, and nulliparous women in which we don't have a predictor of a prior pregnancy. We know African American women are at a higher risk, women with chronic hypertension, and some other risk factors we'll talk about in a moment or so. importantly, not only does it lead to preterm birth that we're talking about today, but in addition, it's a very common cause of maternal death. And as we all know, we're seeing dramatic increases in maternal mortality data statistics in this country. So a very important area. I guess I'm changing the slide, aren't I? So, 59 randomized controlled trials were reviewed by this Cochrane review, and 17% reduction in preeclampsia with low-dose aspirin. That's significant given the life-threatening nature of preeclampsia. And importantly, a 14% reduced risk of stillbirth, and 8% reduced risk of preterm birth. The antiplatelet agents do have a benefit when preventing preeclampsia, and frankly, it makes sense. The aspirin is very effective in heart disease and other conditions like that, and the placenta is a highly vascular organ, so it makes sense that there would be some efficacy here as well as in heart disease and other conditions. So the risk factors the U.S. Prenatal Services Task Force put out, we have the high risk factors, history of preeclampsia, and we have women with chronic hypertension, women with diabetes or renal disease or autoimmune disease. If they have any of those risk factors, these women, it's recommended that they do get aspirin prenatally. During the modest risk factors are the ones where people have not quite clinically come together around. So, and really all it takes is 2 or more of these for there to be a recommendation that aspirin be considered. So, obviously first-time pregnancies, obesity, family history of preeclampsia in a mother or sister, because we know it's linked in a family, and then sociodemographic characteristics, African-American race, low socioeconomic status, age, personal history. So basically 2 or more of these moderate would indicate consideration of aspirin. So you can see how in certain populations the rate of aspirin use could be quite high depending on who they are. And again, it's highly effective and it costs next to nothing. Before I get there, let me just say that we have, as I said earlier, have not identified any system who has put this into place. There is some work going up in Boston, at the Boston Medical Center, where they have put a fairly deliberate plan in place and are screening every woman who comes into the clinic for this and have begun to initiate it. And I've seen fairly impressive results. That's largely inner-city African-American population, which, as you look down these risk factors between the moderate risk factors and even the high risk factors, would be a group that could benefit. So one of the things we're looking at is how do we promote this in high-risk populations. There are also, of course, in all these, like in all these things, systematic problems. We've learned that at times when the woman with Medicaid takes a prescription for aspirin at the pharmacy, the computers will kick it out, saying that aspirin should not be given in pregnant women. So there's a lot of work we need to do to align our systems to get the results we need to get. Am I doing 17P, Lisa? Or are you?
Yes, you are.
Oh, okay, thanks. I'll do whatever Lisa tells me. So 17P, we all know about this, and I think those of you involved in the COIN and other quality improvement initiatives have worked on this. We think that it is a really important modifiable risk factor when a woman has a history of preterm birth to be given the aspirin, to be given, 17P, reduction of up to 33% in preterm birth. You know, again, major, but what are we seeing? Unfortunately, if we look at the data from Oregon, where they looked to see if a woman had had 4 or more shots, not the full series between 16 to 18 weeks and 35 weeks, they used 4 or more and looked at Medicaid women and found that women with a history of a prior preterm birth, less than 10% of it received the 4 doses. North Carolina did a study looking at this after about 8 years of concerted effort in terms of payment, education providers, and patients. They used this criteria, a single dose being billed for, and less than 49% of women had a single dose. It was also really important to consider what was behind some of this. There's a strong tendency to say, well, the doctors don't know about it. That actually might be true in some, sadly speaking, but I think there's more to it than that. There's also a tendency to say, well, these aren't health literate women, for example, and that's why they don't accept it. And I think that's an area where if you just consider social determinants, you can find out that's not probably the right explanation at all. So let me see the next slide here before I go back. So here's what it says. So as we look at the fall off, the biggest reason for falling off was they weren't offered 17P by the doctor. So, you know, perhaps, as I said, there may be some doctors who don't know about this, but I think actually we have to look at the system here and see what is involved in a provider organizing their practice to give this. And unfortunately for many providers, they see multiple insurance companies that require prior authorization of the 17P. So that means multiple interchanges with the insurance provider, which takes a lot of the provider's time. There's questions about will the provider be billed, paid or not for it? Will a woman show up for a shot, or will the provider end up having to lose the money on it? So there's a lot of systematic things that we have to take care of so that the provider who knows about it can offer it. Now when the next drop off is women who did not accept it. And here's where you may say, well, they're not health literate, they're not motivated, whatever. Non-compliant is the old one. But in fact, if you're looking at Medicaid women that work in a job, a social or a service job, there's a good chance they don't have paid time off or paid sick leave. So how would they possibly leave their employer and go once a week to the doctor's office to receive a shot? That could cost them their job, that could cost them therefore their home, their apartment, and so we really have to solve that problem also. There are examples of where this has been solved. One, I'll get to Massachusetts in a second, but in Puerto Rico, they have formed a group of the perinatologists got together, they formed a group where all a doctor has to do is to fax to them the name of the patient and the indication. That group then will work with each of the insurance companies to get it prior authorized, and then the supplies will be shipped directly to the pregnant woman. So the doctor is out of the hassle of having to stock it, supply it, do the prior authorization. What this group will then do is send out a nurse to meet the patient at school, at work, at home, wherever she is, so that if she's working in a job and doesn't have that paid sick time, can't go for 2 hours a week to the doctor, they will meet her wherever she is and give her the shot. They have over 96% completion of the full series. So there's an example of where they solve the doctor's problem, they solve the patient's problem, and it actually works, showing the importance of lining the system up beyond just education. Good work going on in Massachusetts. We did have meeting with about 100 different stakeholders up there from a number of different areas. Importantly, look at the fact that it include the pharmacies, home health, health plans, so really bringing the whole system together. And they developed the web-based progesterone toolkit, including the self-assessment tool for the practice, for the insurers, what is covered, and of course we don't want them to have to prior authorize this. There's a clinical improvement guide and educational material for providers and consumers. And so this is being rolled out now, and we're hoping to see, as a continuing education, we're hoping to see real progress from this also. So I will turn it back to you, Lisa, now.
Great. Thank you, Paul. And so one additional intervention that's very exciting is one around group prenatal care. Group prenatal care is an evidence-based model that brings pregnant women with similar due dates together for prenatal care with their providers. The care is delivered in a group setting, and it includes an opportunity for the pregnant woman to see her provider, but also an opportunity to have group discussions on various topics, all in one visit, with where women who are also pregnant around similar time periods are there together. The group size can vary, but generally it's optimally around 8 to 12 women. Individual intake is an individual visit. Generally, they enter into the group, ideally during their first trimester, but that may not always happen. The women are, taught to do some important skills themselves. Taking their own blood pressure, for example, is an important skill. And then they have these sessions that are generally around 90 minutes or so. They are facilitated around various topics, depending on, again, what the needs of the group are. But generally throughout the time period of group prenatal care, they're going to learn about the importance of nutrition, hydration, what does swelling mean, how to identify what may be some early warning signs that your blood pressure may be elevated, et cetera. And group prenatal care, there have been many studies, but they clearly show that that women that participate in group prenatal care have higher birth rates and reduction in preterm births, particularly in women of color, African American women. They have higher rates of breastfeeding initiation and feel more empowered and satisfied with their care. So the March of Dimes has been supporting group prenatal care models such as centering pregnancy over the years, and we also are continuing to work on a supportive pregnancy care model of group prenatal care as an intervention that hopefully there can be more spread and scale. So it's just another example of the types of things that through the collaborative we are hoping to see how we accelerate, we spread, we scale, we learn from each other these different models and interventions that can address prenatal, preterm birth. So as we wrap up, we want to make sure that you are, again, aware that the collaborative is active. Its work groups are active. This is a calendar of our meetings. Sometimes these do change, so we certainly invite you to go to the collaborative website, marchofdimes.org/collaborative, to stay abreast of what our meeting schedules, what those dates are. But if you're interested particularly in joining a work group, then please email the collaborative at March of Dimes, collaborative@marchofdimes.org, and we'll be happy to make sure you get that specific information. The next full collaborative meeting is slated for December, but we will have work groups that will be meeting in the time period leading up to December. And then finally, again, this is just a snapshot of the cover page of the collaborative website. On this site, you will be able to find our newsletter. You will find minutes from the meetings to get you caught up on work that has occurred to date. And again, an opportunity to engage and to share with us. So with that, I believe we now move to our question and answer period.
Thank you so much, Lisa. And thank you so much, Dr. Jarris. We will now open the session up to questions from the audience. We have received several questions already, but if you haven't had a chance to send them yet, please do chat them in. Please note that we might not be able to get to all the questions due to time constraints. Our moderator for this portion is Pat Heinrich, the Infant Mortality Coin Project Director at NICHQ. I will turn it over to Pat, who has several questions, both some that have been pre-submitted by you all and some that have been chatted in live.
Thank you, Lee, and thank you, Dr. Jarris and Dr. Waddell. I think we have some great questions coming in. So first, let's start with those we received before the webinar. The first one is, what is the best way to measure effectiveness of a local prematurity campaign? I have some ideas on that, but I'll let you answer.
Well, okay. Well, then you can tell us if we're right or wrong. I would say a couple of things here. One is engagement. Who is leading? Who is the sort of anchor organization? But also, who is engaged? And do you have the right people across the right areas? So is it just the same old people talking to themselves, or have you invited in groups that you might not otherwise have worked with who can impact it? There's going to be process measures. In terms of, are you meeting? Are you setting agendas? Are you setting goals? Do you know what you're headed toward? And then output measures. Are you, in fact, achieving what you set out to do? Whether that is holding a conference, having a phone call, launching a quality improvement project. And then finally, outcome measures. So those could either be outcomes from a given project. Let's say you began an issue around 17P or Aspirin or group prenatal care or intentionality. Looking at what happened with that project for the people enrolled in it, or the patients, the clinics, or whomever, health departments, did they achieve what they set out to do? And then the highest level of the outcome is if you can possibly look at your community rates of disparities and your community rates of preterm birth, you can track that. But that data, of course, will be lagged. So that's a long answer, but I think between engagement, process, output, and outcome, somewhere in there you want to set some goals to measure how you're doing.
Thank you so much. Perfect answer, I think. Hopefully our question, the person that raised the question, who I'm not sure who that one came from, but hopefully that will definitely answer their query. The next one that came in before the call was, what efforts would have the most impact that a Medicaid plan can tackle, since many women are first getting coverage after becoming pregnant?
Lisa, you want me to take that? You want to take that?
Sure, I'll be glad to start off on that. I think Medicaid is an incredibly important partner in all of the work that we do, particularly both from the clinical practice and the public health practice. And in many places, Medicaid is very engaged with managed care also, or their managed care, supported through managed care plans. And so the opportunity to streamline processes by working collaboratively with the providers that are able to raise, these are some of the barriers to processes that are in place, and then the Medicaid agency being able to help to facilitate simplification of those processes can be very, very helpful to providers. So an example is like the prior authorization forms. Rather than have multiple forms for prior authorization for 17P, can that be one unified form, and even better, no form at all? The other is, the payment types of policies, and what are those policies that Medicaid can put in place to facilitate providers being able to truly serve the women. There are, for providers that are interested in establishing group prenatal care, are there opportunities for Medicaid agencies to financially support that model of care would be an example. So they're very, very important partners in the healthcare system in our state.
I'd also say we shouldn't accept some of these limitations. There are states who have extended the coverage for women, both through expansion or certainly the period of time after pregnancy. It really doesn't make sense to boot somebody off in 6 weeks, so extend that further. So I think working on coverage is important. There's a lot in regards to policies we should look at. For example, can we eliminate prior authorization for like 17P for LARCs? Some plans have policies that you have to fail a prior method before you can get a LARC. Well, what's that about? That's going to cost them a lot of money. We also, for 17P, in addition to we're not requiring prior authorization, or if they do, streamline it between all the managed care plans. But what about covering home care for 17P so the women can get their injections in the home or school, wherever they are? And then, you know, it can go from there out to, for example, one of the, like in Massachusetts, where they have a requirement that insurers cover artificial insemination and assisted reproductive therapies, making sure they have policies that are conducive to promoting single embryo transplant rather than multiple embryos. I think it was about 12% of the preterm birth in Massachusetts is due to assisted reproductive therapy. So there's a lot of policies we want to work with them on, you know, some broad, extending coverage, really being rash about prior authorization, but then others quite specific to the intervention.
Thank you so much. And we do have...
I was just going to add that many state Medicaid agencies have put into place a policy to cover the long-acting reversible contraceptives in the immediate postpartum period. And so that's a really important payment policy change that has occurred in many states, and that facilitates women who want to receive that device before they leave the hospital setting to be able to at least have that covered. There are many other systems, things that have to be put into place. But that's been a very important first step that many Medicaid agencies have put into place in states. And then that can help with that pregnancy interval that we know is important in terms of birth spacing.
Yeah, absolutely.
Thank you so much. And I know we've highlighted quite a number of these kinds of partnerships with Medicaid and our prematurity, our prevention toolkit for IAMCOIN, so folks might want to look at that too. Thank you. All right, let's go to some questions that came in during our call today. The first one is from Susan Whalen. She asked, when looking at disparities in rates of prematurity, is there any research being done to tease out the contribution of the epigenetic changes due to a history of racial trauma and the contribution of biological stress caused by current racism?
It's an excellent question, and I think we're trying to determine now the precise biological mechanism by which exposure to toxic environments, racism, both historical and current, play out. I don't think we've precisely found that biological mechanism, but again, we do think it's epigenetic. We don't know particularly which switches or which genes are engaged. And then we do know certainly about the allopathic load and the increased cortisol, increased inflammation, and those mechanisms. I'm not sure how we would sort out current from past, but for both American Indians and African Americans with a 600-year, 400-year history of racism, it's going to be tough to sort the two out, I believe. But if somebody has the answer to that, I would love to hear it.
So folks on the call, if you'd like to comment or add anything to Dr. Jarris' answer, please either type into the chat or raise your hand and we can unmute you to join us in this conversation. All right, let's go on to a few more questions. We have a couple of questions about the low-dose aspirin. So from Tiffany Buck, her question is, for low-dose aspirin for high-risk women, should the screening be done at intake and started at the beginning of pregnancy, or should the aspirin be started after the first trimester?
In fact, I think the screening should occur in the postpartum visit for a woman who's had that experience. And we're trying to, March Times, produce materials that women can download, and take to their doctor to say, doctor, talk to me about this because here are my risk factors. But no, it should be taken on the intake, and I believe the aspirin begins around 12 weeks. Lisa, do you want to double check me on that? But it begins early in the pregnancy. I can look that up.
12 weeks.
12 weeks, yeah.
Great.
I would also
say that
a lot of these things you want to take advantage of every single appointment, whether that's substance abuse, their hypertensive history, to keep asking and tracking throughout the entire course of the, pre-pregnancy and pregnancy.
Thank you. From Valerie Garrison, she's asking, what are the risks of low-dose aspirin to pregnant women? We mentioned risk.
Yeah, they're remarkably small when they look at large studies. There can be a little bit of an increased risk of abruption, but they found that if you look at the literature, it's very small risks compared to the benefit. Lisa, can you quantify that more than I did?
No.
Okay.
I mean,
Always a risk.
What you said is correct, yeah.
Risk-benefit review, great. Okay, a few more questions about pregnancy clotting disorder. What is being used for pregnancy-induced blood clotting disorder?
What is being used? I think they're, you're asking me, they are using, I can't remember the name of the medicine. I'm sorry if there's any clinicians on the phone, help us out. But not heparin per se, but another long-acting medication inhibits clotting. And I can look that up as we're talking and get back to you if you want.
We can take this offline and answer some of these real clinical ones offline after the call as well.
Okay.
So let's go to a couple questions about the maternal risk assessment. One question is, Dr. Waddell, how do you code the well-child visits that include maternal risk assessment?
I think that's a great question. We would have to follow up with one of the active practices to find, out exactly how they're doing that coding. I don't have an answer to that specifically at the moment about how the coding is being done.
Yeah, if it's a family medicine practice, it's a lot easier because the family medicine practice can bill for services to the mom as they see the mom. For pediatrics, they can't really bill for the mom. But the pediatricians, I believe, can bill for postpartum depression and smoking for parents. I don't believe that the pediatricians can bill for contraceptive counseling. So
if
really
we have any pediatricians on the line that are doing that kind of an assessment and billing for it, please type into the chat and share how you're covering that. All right, then from Rana Seifert, where can I get more information about the potential role of environmental factors such as air quality and endocrine disruptors on premature birth? I get information from the Collaborative on Health and the Environment, but wonder if there are other resources.
Yeah, I would recommend Dr. Google, particularly Dr. Google Academic. We can take a look at that for you and get back some information back to you on it. But there's been a number of studies that do talk about particulate air pollution and rates of preterm birth with a statistical correlation. And I know one of these studies was done in California. We also know that there are certain pesticides based on epidemiologic studies of farm workers and people living close to farm fields where some of these pesticides are associated with much higher rates of preterm birth. And I wish Cindy Pellegrini were on the phone, our government relations person, because one of these is actually an active policy concern right now. But if somebody wants to let us know who you are, we can try to get something to you.
And last question I think we have is about prematurity and breastfeeding. This is, prematurity often leads to cessation of breastfeeding. How are you separating the effects on infant morbidity and mortality of this loss of access to the mother's ongoing immune support that's provided through breast milk from the effects of being born premature?
I think perhaps that is an effect of being born premature, but more and more now we're seeing breast milk being used in NICUs, often supplemented with additional nutrients, but it's the breast milk banking is growing in this country, as well as encouragements for moms to pump and rooms for them to pump, even if their baby is in the NICU and unable to breastfeed directly. There's also, and as you say, the immune benefits to the baby are tremendous. I was talking, and this is completely anecdotal, but one of the NICU leaders at Inova Fairfax was saying that since they have started with their breast milk bank, they have not had a case of necrotizing enterocolitis in the NICU. So clearly there are benefits to it, and we want to continue to expand both the mom's ability to pump and then breastfeed, but also safe breast milk banking.
Great. So the importance of donor milk. Thank you. I think that's all the questions we have. Lee, did anything else come in while we were talking?
No, I think those are all the questions that were asked live today.
All right, so I thank you all for those excellent questions. If we didn't quite answer them and we have any more to add, we will post that after the call. And otherwise, thank you so much for sharing your queries.
Thank you, everyone, for attending today's webinar. We are going to wrap up a bit early and give everyone some time back in their day. Thank you so much, Dr. Jarris and Dr. Waddell, for sharing your insight with us around the Prematurity Campaign Collaborative. I know there are many folks on the line who are really interested in participating and will be following up as they're interested in receiving the slides and potentially participating in the collaborative. For those of you on the line, we encourage you to come to our next Infant Mortality Expert Series webinar. It will be on Thursday, and this will be the last webinar in our series. We'll be talking about state and local health departments and how to align them around maternal and child health. We hope you will join us from 12:30 to 1:30 on Thursday.
And
finally,
if I could,
yeah.
So I was going to put a little advertisement in, if I could.
Yeah.
The March of Dimes is leading a webinar. We have almost 600 people signed up for it now, called Equity and Preterm Birth, A Context for Action. This will be held October 3rd from 3 to 5 p.m. And it's a world-class group of speakers, Dr. Paula Braveman, who has probably published as much as any epidemiologist in the area of race and social determinants and birth outcomes, will be speaking first. Arthur James, who I know many of you know, who's now the Executive Director of the Kirwan Institute, will be speaking. Dr. Don Warren. Don is the chair of the Department of Public Health at North Dakota State University, which has the first and only track for American Indians in MPH. Don is very active in the American Indian community, and he's a Lakota Sioux. So it should be a fantastic presentation, and I believe we may send out to you from this webinar the registration materials, but if you can make it, I think it'll be a great session. We certainly welcome you.
Thank you so much for that information, Dr. Jarris. And yes, we will absolutely send out that information during our follow-up email that will be sent out in the next few days with the recording and the slides from today's webinar. So we hope that you can attend that one as well. And finally, I'd like to give a big thank you to the March of Dimes for co-hosting this webinar today with NICHQ. It's really been fabulous, and we hope that everyone has a wonderful Monday afternoon. Thank you all.
Thank you.
Thank you, everyone, so much for joining us.
Thank you.